What's up, Boards Insiders? Welcome to another episode of the Inside the Boards podcast. I'm Doc Osara from the Doc Osara YouTube channel, dedicated to making videos about surviving college and medical school at youtube.com/Doc Osara.
Welcome to the Inside the Boards podcast, the podcast dedicated to helping you learn to think like a question writer so you can study smarter, not harder, and succeed in medical school.
Welcome to the Inside the Boards podcast. I'm Stuart Bryant. In today's episode, we hear from Doc Osara, who is a neurology intern in Southern California and famous for his YouTube channel. Check him out there. Today, he and Patrick will help you dissect some high-yield neurology questions in preparation for the boards. Because this episode was a little long, I decided to break it up into two parts, so expect one additional question to come later this week. I hope you enjoy.
Welcome to the Inside the Boards Study Smarter series for the USMLE Step 1 and COMLEX Level 1. Today's guest is Doc Osara. That is, I'll let you say your full name.
Mohammed Hajigasimi Osara.
That's why I was going to let you do it.
I just go by Doc Osara.
Yep. And I could see why. Like, your huge YouTube channel, / Mohammed, and the rest of your names, might be a little hard for search engine optimization, but people can. Patients. And for patients, too. But you can find his great study advice, tons of videos, hundreds of thousands, probably millions at this point, of views at youtube.com/Doc Osara. So that's OSSAREH, correct?
That's right. And actually, I think we just hit 5 million views.
5 million?
Right.
Oh man, we've got some catching up to do on the audio side of things. But we're welcoming him today on the podcast because he is, like us, committed to free open access medical, advice / education, and is a neurology resident or intern who will be a neurology resident. So he's going to provide some expertise and learning related to some neuroscience questions for Step 1 level stuff. But before we get into that, let's talk a little bit about the growth of your channel. What inspired you to... And he's being paged.
That's the hospital.
Real life medicine right there.
Yep, answering pages, even at home.
I bet all the students listening, they're like, oh my gosh, I cannot wait to be a real doctor. And
when I was a third-year med student, having a pager to me was like the coolest thing ever. I felt like I had a Lamborghini. And I would sit there eagerly as I walked the wards, hoping to get a page. Yeah. You never do. Now, gosh, when you're doing the night flow and it's 3 a.m. and you get another page... I don't know what I was thinking as a third-year student.
Yeah, I know, because I also thought it was cool, like, as an intern, maybe for, like, a week, maybe 2 weeks, maybe, and then I was like, you know what, this kind of sucks. All right, so tell us about your channel. What inspired you to, I'm sure, take a lot of time to provide some advice and guidance for pre-meds and medical students via YouTube?
So when I was back in college, I got super lucky. I went to a great college called St. Mary's College of California. It's in the East Bay in the small little city up in the hills of Moraga. Super small classrooms. Every upper division class is max at 16 students and 1 PhD. No TAs, no big lecture halls, super small and intimate. Really kind of a unique experience. And I didn't do too well. And I said this in many of my videos. I did not do too well in high school. I wasn't that dedicated. I wasn't really challenged. I was just kind of doing my own thing, playing around. And then I thankfully went to a good college, got a lot of intensive mentoring by people who showed an interest in me. And I also had I wanted to perform well. And I got lucky in that professors were willing to invest time in me to kind of make me stronger. And I was looking back, and I would call my friends on the phone back in high school and try to share the advice I was getting. And it became, quite cumbersome pretty early on. One friend would talk to another and he'd be like, hey, can you talk to this guy too, and kind of share stuff. And then eventually I realized I needed like at least some type of platform. I could just make a video or put my audio out there, and then my friends could just see it. It would just save me time, and then I could follow up with them and we could hang out or whatever. And back then, YouTube was still in its early ages. I had a little Sony camera webcam that I thought was super cool back then. And I would literally put it on a shoebox and just record myself, thinking it was my friends that I was talking to, just trying to share experience and let them know how it was going. And then for whatever reason, YouTube, people started finding me. There wasn't that many of us doing that kind of work at YouTube at the time. People in college, people who were pre-med, even high school students were reaching out saying, hey, thanks for the videos. Here's some questions. What do you think? And that's kind of how it started off in the early days. It was just me trying to help my friends, and people kind of found me on the internet. And then since then, I kept doing it through college. I did it through med school, did it through MBA year, did it through intern year so far. It just kind of grew, and the channel went with me. It went through the college years. It went through pre-med, went all through med school, included business, went through the match with me, and now is including residency work as well.
Okay, cool. And I did notice, so you have a minor in theology and religious studies.
That's right. So my college was a Catholic liberal arts school.
So was mine. We had about 2,500 undergrads. And I actually studied theology and philosophy as an undergraduate student. So I guess we're in good company together.
No, I think I remember being there, and I was studying biology like most pre-meds do. And at that school, you had to take one or two courses just to kind of graduate in theology and philosophy. And I started to realize this really aided my understanding of medicine, not so much the science side, but more the art and human perspective. And I got to say, who I am today and probably the worldview I have was largely impacted by the studying I did in college, and not so much the basic science, to be honest, but much more that kind of philosophy and learning how to think at an earlier age.
Yeah, definitely. All right. So how do you plan your videos? You're sitting in rounds one day and you're like, I need to make a video on the 4 essential study habits for medical students.
And that is kind of how my brain works. I wish I had a more organized way of life, but my viewers honestly are such a big inspiration. I will get comments and questions and emails about, hey, could you make a video about this? And I'll read it. I'm like, that's a genius idea. Thanks. And I'll reply with, hopefully I'll make that the next month or so. But sometimes, I literally now have a piece of paper next to my bed on the nightstand, because I do wake up sometimes in the middle of the night with an idea, as embarrassing and nerdy as that sounds. Or I'm in the car. So now I have like a notepad in the car by my bed. I just don't have one in the shower. But like, I just kind of get ideas randomly. I don't know where they come from. I wish I knew the triggers. If this was doctoral and I was trying to work up epilepsy, I don't know the trigger. Who knows?
2 questions. First, which video is your favorite?
Probably the study of the power of habits.
Okay.
Because that kind of hits me, I think, where I like to talk about the most, which is strategy. And just like simple, people use the word life hacks. That's like a popular phrase, but just simple strategy to get through life and perform better. The habits video, I talk, because it's very personal to me. I talk about how I just kind of give myself a harder work ethic, how I trick myself into working more. You can tell people what to study and how, but if they don't have the good infrastructure, they're going to probably have a bit of difficulty. So that one was fun because I got to, I read a couple of good books. I used it in practice, and I just got so excited. It kind of reminded me back of the super early days when I was just dying to share info with people.
So you're talking the how to study when you don't want to, the power of
Exactly.
habits. Okay. I'm reading Cal Newport's Deep Work now. So
yeah, I read that book actually.
I know it's phenomenal. I actually read A.G. Sertalange, the Dominican priest who wrote The Intellectual Life, probably like 10 years ago, and he quotes extensively from that book. And I just my heart started beating so fast when he quoted him, because I love that book, and I was like, yeah, this is great. This is like a modern version of that. All right, so your favorite one. How to study when you don't want to, the power of habits. If you can provide advice on that, I am sure that is valuable, especially going into dedicated step 1 prep time. So aside from that, though, what has been the most successful or highest number of views video?
So by far, the guide to the complete physical exam is our most popular video. Last I checked, and that was a few months ago, I think it was at 860,000 views or something.
Yeah, right. It was this morning and you know it.
I know. I wish I had that much time now. But that one is by far our most famous. I actually made that video as a first year medical student with one of my classmates. And actually, he's going to be at USC with me next year. We're both going to be in the same hospital for residency, ironically.
Cool.
I went to med school at UC Irvine, and we have this course called Clinical Foundations. Some schools call it like the basics of doctoring, where they teach you how to do a physical, get history, interact with patients, etc. And I mean, for me, the physical exam was probably one of the most exciting parts of getting into medicine. I love it. I feel like it gives a deep connection between physician and patient. And so when I started med school, I was deeply excited to learn the physical exam. And I met my friend, Bubba is his name, and he also liked the physical exam. And I was like, man, why don't we make like a comprehensive video showing the stuff we've been learning as med students on how to make a physical exam? And maybe in a few years, we'll like look back and say, oh, that's how we used to do it by the textbook, perhaps. And maybe other students can see it as well. Because we were really into it. And we set up a webcam that we connected to a laptop and put that on a tripod. We found a study area, got some sheets and some bed, and we begged the hospital for a gown to look kind of professional in the video. And I had my short white coat on looking really geeky. And we just did the whole physical exam. And for some reason, that thing just did really well. People wanted to see it.
All right, cool. I did not look at that one, but I will because I'm looking at the screenshot now. So let's get into a little bit about neurology, which my guess is the physical exam, probably your love for that, influenced your decision on that specialty. And we've got some questions that hopefully can illustrate not only your deep passion for the physical exam, which I'm sure will continue to exist in your specialty, but less and less so in a lot of others. First one is a 19-year-old woman who comes to the emergency department because of fever, confusion, and headache. Her medical history is significant for herpes simplex virus. Lumbar puncture reveals increased protein and increased lymphocytes, and the glucose is 66 milligrams per deciliter. An MRI shows increased signal in the left temporal lobe. And the interrogatory is, which of the following visual defects is most likely present in this patient? A, bitemporal hemianopsia, everybody's favorite hemianopsia, by the way. B, left eye anopsia. C, left inferior homonymous quadrantanopia. D, right eye hemianopsia. Or E, right superior homonymous quadrantanopia. Ugh.
And you wonder why no one wants to do neuro.
Or ophthalmology.
Correct.
I've already in the past month complained about having to learn things about the eye, so I will refrain. All right, you're studying for step 1, and you just see all these like unpronounceable answer choices. How do you approach this question?
Okay. This question is not hard, but it really does teach one key principle. And that's you don't have to know everything. Just at first know the big picture ideas. And over time, you'll know more. The stupid analogy from Shrek of an onion, you don't have to know the whole onion. Just try to just get the core of it. And then over time, you can add on layers and layers of more detail. So starting with the question, I just took step 3 2 weeks ago, and I still do this philosophy. I read the last sentence first. I like that strategy because it tells me what are people asking me. Whether it's what's the best test, what kind of symptoms. So I kind of get a sense of I know what I'm doing during the question. Maybe not everyone does that, but I just like it. So starting with the question, she's coming into the emergency department. So I know it's a hyperacute or acute problem. So not subacute on chronic, not chronic. Or it could be, but something's flaring enough that she came to the ED. Fever, confusion, and a headache. I mean, you probably are going to be thinking meningitis to some degree.
Yep.
Headache, confusion. Okay, that could be like encephalopathy maybe, or ICP increase, but the fever kind of makes you think meningitis. Someone who's young, 19, probably isn't going to be having a brain bleed or some kind of like cancer at this young of an age. So keep it simple, probably meningitis. she's got a history of herpes simplex virus. They're probably, I mean, that could be a red herring, but they're probably telling you for a reason. And it's oral herpes, so that's close to the face and cranial nerves. And then they're just giving you great data. They did an LP, showed increased protein. Overall, whenever you look at an LP, increased protein is a sign of inflammation. So if your protein's high, there's some type of irritation or inflammation going on in there. Lymphocytes, white counts high, and glucose is 66. So normal glucose CSF, 40 to 70. So glucose is normal. So if I was thinking meningitis, you're going to think viral versus bacterial. Normal glucose, it should go down. So probably something viral. Then they even give you more great data. They got an MRI, and it showed increased signal in the left temporal lobe. And the question, which we knew, which of the following is, I guess we'll say, most likely to be in this patient? So they're giving us some key data. You're already thinking meningitis. You're thinking more viral compared to bacterial because the glucose is normal. And the fact that the temporal lobe lit up and she has a history of HSV, you're thinking HSV encephalitis. And the reason is, we'll go through like the CSF findings a little more detailed in a minute, but bitemporal or temporal lobe enhancement in a meningitis patient is HSV until proven otherwise.
Yeah.
Start the patient on acyclovir, no questions. You can be wrong later. So that's, I think, the first key is knowing how to analyze your CSF. So if you can't get the CSF right, you probably won't get the other questions right. So real basics, if you've got a normal CSF, you shouldn't really have many white cells, like 0 to 5. Like I said, normal glucose, 40 to 70, and you shouldn't have a lot of protein. Bacterial meningitis, we all know it well. Tons of white blood cells. And that makes sense. It's a bacterial infection. White cells are going to be there. It's like a pus like anywhere else. You're going to have low glucose, bacteria eating up sugar, because that's what they do. And again, high protein, because protein's an inflammatory marker. There's something growing in there. It's irritating stuff, inflammation, you're going to have it. But then compare that to viral meningitis. You'll have an increase in white cells, but not that much. Normal glucose, and you'll have an elevated protein, but not through the roof. So in this case, we thought about it. Temporal lobe enhancement, totally almost a buzzword for viral encephalitis. And also normal glucose, making you feel much more comfortable, and she's got a history. So now you're thinking, oh man, I got this. The answer's got to be HSV encephalitis. I'm a neurologist. And then the answer choices are another level. You're like, oh my Lord, what do they do to me?
Right, exactly.
So this is not that hard. People worry about, oh, is this too neuro-opto for me? This is easier than learning like heart failure, because there's only like 5 things to know. Don't learn the whole pathway and every little nuance. Just learn the big deals. So all you got to think about is the actual, how does vision get made? So you start at the macula and you move backwards. So if someone had a lesion to the optic nerve, they're going to have option B, left eye anopsia. So the whole left optic nerve or the whole optic nerve is hit, the whole eye is out. This is all before the chiasm. So if you hit that early, the vision's out in that eye. Well, this person doesn't have left eye anopsia. They have a different finding, because we're going to be much more back if we're temporal.
Yeah.
Next one after the optic nerve is going to be the optic chiasm. And classically, people love optic chiasm. If you have a lesion there, you're going to get bitemporal hemanopsia, or like horse blinders, as people like to call them. So it's not option A. It's not bitemporal hemanopsia, because again, temporal lobe is much more back. Now, if you hit one of the optic tracts, you're going to get, a right or left eye hemanopsia. And that means one, like the left side of your vision or the right side of your vision is just gone, but that's post-track. Then comes the actual valuable parts that people often will get quizzed on the wards, and is honestly a much harder question, so it's probably why it's being asked here, is after the optic tract is Meyer's loops, and that's in the temporal lobe. And after the Meyer's loops, what you're going to care about is what's called the Dorsic optic radiation, and that's in the parietal lobe. So knowing the word Meyer's loops and Dorsic optic radiation, that doesn't really matter. Just know in the pathway, you're in the temporal lobe, and then you're in the parietal lobe. So if you have a lesion in Meyer's loops, the top left or some type of top superior right or left is going to be hit. And if you go back to the parietal, it's the lower part. That's all you got to memorize. Meyer's is going to be superior, and in the parietal lobe, it'll be inferior. So this patient comes in, they have herpes simplex. We know it's a temporal lobe lesion. All you got to know from neuroopto is temporal lobe lesion. Okay, temporal lobe, that's Myers loops. That's a superior hit above. And they don't even ask you a left-right differentiation, which would be too fancy for the wards. So that's all you got to know. Not hard. All you got to know is temporal lobe, Myers loops, the superior part will be hit. Go down to the parietal lobe, the lower part will be hit. It kind of makes sense. And anything before that, you can pretty easily figure out. Optic chiasm, everyone loves bitemporal hymenopsia. You hit the track, obviously you've already crossed and you're down to one-sided vision, and otherwise optic nerve, the whole thing's gone on one side.
Got it. So really the takeaway point here is your temporal lobe's messed up. If you're going to have a visual defect, because of that, it's going to be a superior homonymous quadrantinopia, which was choice E.
And people use the phrase pie in the sky for that.
Oh, that's right. I totally forgot about that. That's true.
There you go.
Yeah, that's excellent. That was all pretty high yield. Do you have any other
That's all. I mean, we could talk about herpes simplex.
Ad nauseum, yeah.
Ad nauseum. We talked about, I think the key is knowing CSF findings, the glucose, how high is the white count, do you have an inflammatory reaction or not? That'll help you. The MRI findings of bitemporal enhancement or even unilateral enhancement. And then if you hit temporal, it's going to be superior. Or if you hit the parietal lobe, it's going to be an inferior vision loss.
Okay. And I guess the one other point is this is specifically HSV1, correct, that is associated with viral encephalitis.
That's right. And that makes sense. HSV1 being more oral and HSV2 being more genital. HSV1 going into the ganglion and then kind of reactivates and can hit the CNS.
Okay, got it.
But just so you know, HSV2 can clearly be there. You can get HSV2 in the mouth as well.
Yeah, and I suppose a pediatric population in terms of neonates have the potential to get an HSV2 CNS infection shortly after birth if their mom is afflicted with that virus.
Exactly.
All right, let's move on. Next.
Okay.
We have a 57-year-old man coming to the office because of leg pain and urinary incontinence for the past 2 years.
Mm-hmm.
He says he can't remember ever seeing a doctor before, and his medical history is therefore uncertain. The pain shoots down the legs and has a sharp, burning characteristic to it. When asked to walk, he lifts his knees high and slaps his feet down, placing them widely and irregularly. Which of the following is the most likely diagnosis? And our answer choices here are A, amyotrophic lateral sclerosis, B, Brown-Séquard syndrome, C, discitis, D, tabes dorsalis, or E, transverse myelitis.
Now, this is the kind of question that I used to hate studying for step one. I always felt like it was way too outside of my range, simply because there were so many findings in the actual question stem. So they're asking you what's the most likely diagnosis, or what is the diagnosis? So the guy's a bit older, he's 57, he comes in with leg pain. Okay, urinary incontinence. Anyone with urinary incontinence, red flag. If it's, you're worried, is it something going on with the spinal cord now? But it's urinary incontinence for 2 years. So it's not a hyperacute problem.
Yeah.
It's actually a chronic problem. He never goes to a doctor. Okay, so maybe, not a dead giveaway, but maybe something bruised in him that he never got treated. But it would be pretty weird to have a serious spinal cord problem that you never go get treatment for. But this is the key. Leg pain shoots down his legs. We can also call that lancinating pains. Mm-hmm. Sharp burning characteristics to them. And when he walks, he has to do this high steppage, an irregular gait. And why you have to do that is usually dorsal column affection, where you can't tell where your body is in space, so you overcompensate into this kind of silly gait. So the choices really kind of help you out a lot. The first choice is amyotropic lateral sclerosis. And this pure motor neuron disease, both upper and lower motor neuron, key finding that I've seen ALS in real life, and you often will see it. And frequently people will put this on a board question because it's very specific, and that's going to be tongue fasciculations. If you see it or not, that's a great one to see. That super helps you. But if it doesn't, it's okay. Pure motor neuron disease. And the bowel and bladder are absolutely spared. So someone who's having urinary incontinence can't be ALS.
Got it.
And just as a high yield point for ALS, only one treatment, riluzole. Just in case you ever get asked, we only have one treatment. So start with an R, R-I-Z. Just memorize that, I guess. But honestly, I did. I was like, riluzole, that's all I need to know. It's a pure motor neuron disease. And that's the key. People with ALS, I mean, there was the ice bucket challenge, have pure motor and upper motor neuron lesions, but that's all they have. It's kind of the interesting thing. They're mentally and autonomics are all intact. So pure motor neuron disease is all you have to really know. And if it's upper motor neuron or lower motor neuron, you can see cool things like tongue fasciculations that you don't really see in other conditions. Brown-Séquard syndrome, you automatically know from that that's a spinal cord problem, hemisection of the spinal cord, usually trauma, could be a tumor, could be infection, or super cool, could be infection. And this, this is like a more classic one, the IPSY and the contralateral symptoms. Yeah. If you look in a full neuro textbook, this gets annoyingly long, but keeping it like core for step one, at the level of the lesion where we hemisected on that same side, we lose sensory at that lesion, and we lose dorsal column below that region. And on the opposite side, it's that same level, you lose spinal thalamic tract. That sounds confusing probably from how I said it, because it's neurology. They use fancy words to confuse you, but they wear bow ties, so it's okay.
Wait, is that intentional? Because I always felt like it was.
It is, but let me tell you in a nice way, I'm going to try to make it simple. So ipsilateral, where the lesion is where they can't feel. You start touching, they can't feel it. And that same side, the dorsal column's affected. So they don't have proprioception. They don't know where their arms are in space. They can't feel vibration. They can't tell tactile. And that's on the same side. And only thing you need to know for the opposite side is pain and temperature. So you do have to memorize. Same side, you have a line of sensory where the lesion is, and on that side, the dorsal columns hit, and on the opposite side, pain and temperature with the spinal thalamal tract. We don't hear any about this in the case. Maybe some dorsal column stuff, but we don't hear anything about a focused lesion. There's no IPSY contra component. The guy seems pretty symmetrical. So again, pretty unlike. And Brown-Séquard's very specific presentation. So if you're seeing an IPSY dorsolateral and a contralateral spinal thalamic, it's going to be Brown-Séquard. They're not going to trick you. So that's a pretty easy one you can rule out quickly. Next one is discitis, which just means an infection of the intervertebral disc. This is going to look like a severe back pain patient. You touch their back, they're screaming. We don't get this symptom again. We're getting like, guy's been uncomfortable for 2 years with leg pain, not the guy's dying in pain in front of you. Second, patients are going to have a lack of mobility, not this like weird high steppage gait. And they're going to be sick. They could have an epidural abscess. They could be showing up in the ICU or the wards with sepsis or septic shock. So it doesn't look like a localized thing. It looks much more spread out to this guy. Urinary incontinence, legs are acting weird bilaterally, not so localized like a true little infected thing like this discitis. Just because it's around the spinal cord doesn't mean you're going to have a full neuro symptom. Anything can be infected. Next one is tabes dorsalis, which is the right answer in this case. And that's because the guy's got tertiary syphilis. Who would have thought?
It just comes out of nowhere. Seems like a nice guy. He's 57, doesn't go to the doctor, so he's not like bothering you. You know, he's got like all these symptoms. Then boom, tabes dorsalis.
And that's the interesting thing. When I first read the case, my mind didn't go to tabes dorsalis. I was like, what are the options here? What are they trying to get at? Because it's not like no one thinks about tertiary syphilis or tabes dorsalis that quickly. I mean, it's not something that's on our radar. I mean, how frequently do you even see syphilis anymore or the later manifestations? Unless you're kind of in more rural or in more of a county program. It's just not very common.
Or you're listening to this podcast, in which case you'll probably see it 3 times within the next month just because we brought it up.
You're welcome. But tabes dorsalis is a big deal. Tertiary syphilis is tested because who the hell thinks about it?
Yeah.
And I like tertiary syphilis. So what is it? Tabes dorsalis. So who gets syphilis? I mean, we know MSM, HIV-infected patients, and HIV-infected patients are much more likely to progress up and get neurosyphilis versus others. We all know it's treponema pallidum, spirochetes. All right, so you got someone, they had primary syphilis. They didn't go to the doctor, I guess. The guy didn't get penicillin because he doesn't go to the doctor much. He probably got some stages of secondary syphilis. Again, who knows what he was doing. And now tertiary syphilis comes along and he has tabes dorsalis. So tabes dorsalis literally translates into the decay of the back. dorsalis being the dorsal column. So if dorsal column is affected, we're going to have some key findings. One, for this guy, he has lancinating pains. Like he says, the pain shoots down my leg. He's got urinary incontinence. Now, the next option is transverse myelitis, which also has urinary incontinence. But this guy's had it for 2 years. So it's not a hyperacute thing like you see in transverse myelitis. It's slow. So tabes dorsalis, you do get neurogenic urinary incontinence, but it's not overnight. And when you get it, these people, for some reason, have been away. So lancinating pain, he does have urinary incontinence, and he also has this sensory ataxia. This guy has a very weird gait. He lifts his knees high and slaps them down the floor because he can't tell where his feet are in space. He lacks proprioception. So it's kind of if you think about it in the sense that it's urinary incontinence, which only a few things have. It's been going on for 2 years. He's got leg pain, which is a very kind of a thing you see with tabes dorsalis, and he has poor proprioception, so dorsal column's affected. It all kind of points to tabes dorsalis at this point.
Yeah, so if I were writing this question, I probably would have made it about like Nietzsche. Do you know the story of Nietzsche? Friedrich Nietzsche, the philosopher. He apparently went and listened to Wagner's Ring Cycle, Der Ring des Nibelungen. You know, it's got the Flight of the Valkyries in there. And he was so inspired by this magnum opus as sort of like a statement of the Uberman that he went to a Leipzig brothel, deliberately infected himself, the story goes, with syphilis as sort of like an affront to God. And then later probably had a very similar clinical picture to the person in this vignette, but also went mad and died of neurosyphilis. But I'm sure like right before dying, he was, you know, doing this high stepping gait, had these lancinating pains. Poor guy.
Yeah, poor guy. And of course, 2 more things. One, Argyle Robertson pupil. It accommodates but doesn't react, kind of like with our steroid prostitution. And a side point here, just because we're talking about tertiary syphilis and the actual management's interesting. So most things with syphilis we treat with penicillin, right? If you got primary, we give you IM penicillin. If you have even secondary syphilis, we still give you IM penicillin. There's only one case in which you give someone IV penicillin, and that's neurosyphilis.
Yep.
So simple to know. Everyone's getting IM. It can be for the duration varies on how long you've had it. But if you've got neurosyphilis, you're getting IV penicillin. Now, what if you're allergic to penicillin? Too bad. It's penicillin. You're going to get desensitized. So that's how good penicillin is for these problems. You have neurosyphilis and you start complaining to me about your pen allergy, we're going to desensitize you, and then I'm going to give you penicillin to fix it. So side point here, always treating with penicillin. Just know the IM IV route difference. And too bad if you're allergic, you're getting it anyways.
Thank you. That was a very succinct summary of some high-yield syphilis points, and very forceful too. I'm sure your bedside manner is not at all the delivery in that manner.
But that's how I think about it in my head to remember it. He's getting it whether he likes it or not.
I like it. All
right, and last option here is transverse myelitis. And when I first read the question, whenever I hear urinary incontinence, I just think of transverse myelitis. But for 2 years, come on. So transverse myelitis, neuroinflammatory condition of the spinal cord, usually post-infectious, can be bacterial, can be virus. It can even be post-vaccine. Oh, that's kind of awkward. Or if you have any autoimmune disease. But the key with transverse myelitis, and people love to pimp on this on the wards, bimodal distribution. You're young, 10 to 19. You're a bit older, 30 to 39. That's when these people get it for some reason. And these people do have both sensory and autonomic dysfunction. So in this case, it'll be bowel, it'll be bladder, it'll be sexual, but this is going to be acute onset. Usually the case is going to be someone had a GI thing, they had a upper uri thing. A couple of days later, they start to feel this. So it's not going to be, guy was fine for 2 years and then now comes in with urinary incontinence.
Got it.
So transverse myelitis, see some kind of infection prior, acute onset, demyelination, bimodal age distribution versus tertiary syphilis in a guy who's going to have you don't hear about these lancinating pains and transverse myelitis. You don't hear about dorsal column weird steppage gait. It's just sensory and autonomics.
All right, thanks for listening to our part 1 of our Neuro review with Doc Osara. Like I said, I'll have the next episode out in a couple of days with an additional follow-up question that'll help reinforce some of the material in this podcast today. In the meantime, help us by going to iTunes and reviewing the podcast, and sharing the podcast with your medical student friends who are in need of help while studying for the boards. If you share the podcast on social media, you are entered to win a $50 Amazon gift card at the end of the Study Smarter series. And thanks to James from the band 2 O'Clock Courage for providing the song. Happy studying!
Inside the Boards is not affiliated with the United States Medical Licensing Examination, Comprehensive Osteopathic Medical Licensing Examination, National Board of Medical Examiners, National Board of Osteopathic Medical Examiners, or any other licensing or examination body. All exam names or other trademarks are the property of the respective trademark owners. Content discussed during this program is the property of Inside the Boards or the attributed owner and may not be reproduced without permission from the appropriate entity. Inside the Boards fully adheres to the respective policies on irregular behavior outlined by the aforementioned credentialing bodies. All content discussed is for educational purposes and should not be construed as medical advice.